What is articulating with the inferior articular process?
C2. C2.
What part of C2?
The superior articulating
The
facet.
superior articular facet of C2 will articulate with the inferior of C1. Yes. Good. Good, good, good. Okay. Orientation of vertebrae. We talked a little bit about this before. I don't want you to get too hung up on this. But most of the rotation in the cervical spine occurs at the atlantoaxial joint, C1 and C2. Our spinal anatomy hasn't changed. We still have a disc with a nucleus propulsus, annulus fibrosus surrounding that. We still have facet joints. We got ligamentum flavum. We've got anterior longitudinal ligament, posterior longitudinal ligament, ligamentum nuchae, all that good stuff. Interspinous ligaments, supraspinous ligament. Anterior longitudinal ligament will limit what motion? Extension. Extension. Can we see that? If we've got ligaments here, it will limit this movement. Okay. What else? Intervertebral foramen. If we see a narrowing of the I don't know if y'all had this yet. Y'all talked about stenosis in yet? In pathology? I'll let you slide then.
Yeah.
So anterior longitudinal ligament here, posterior here, supraspinous right here, interspinous here, and then the ligamentum flavum runs from base of skull to pelvis, in front of and behind the lamina, so it's all through here. Surrounds the facet joint capsules. They will call this the yellow ligament. It's the strongest one, protecting the spinal cord and the nerves. Cervical spine, we saw this picture earlier today. Here is our articular facets of C1 where the occiput will sit. The dens of C2 here. What kind of joint is this?
Pivot.
That is a pivot joint. Very good. Right and left deep concavity of superior facets. We talked about that. What kind of motion is this called? Capital flexion and extension, meaning the capitis muscles, okay? Capital flexion and extension. Touch on that in a few more minutes. Intervertebral joints, we talked about that. Zygapophyseal joints are facet joints. So if you see either Z joints or facet joints, they're the same thing. Motion coupling, I don't know there'd be a whole lot about that, but again, rotation and side bend occur to the same side. So if you side bend left, everything's going to angle that way. And if you rotate to the right, the sets will do the same. But don't worry too much about that. That's more of an evaluation tool. Capsular pattern is pretty equal, not significant, even flexion, not a big deal. Don't worry about that. SCM we talked about this morning. Mastoid process to the clavicle and the sternum. Rotates head to the opposite side, and of course flexes the neck. Anything that's going to cross the cervical spine is going to flex the neck anteriorly. All right, so we did not do this earlier, but I think it's important. So palpate your mastoid processes, and then I want you to slide inferior to that. And you'll kind of get to that little hollow space, and if you push really hard there, it feels kind of bony and it doesn't feel real good. That is your transverse processes of C2. That's how wide it is, okay? So that is an easy palpation to do. Gives you some landmark there. That's the level of C2. Okay. Longus coli, anterior, super deep. Again, really tender with whiplash. Think about whiplash. What is the mechanism there? So you're sitting, you get hit from behind, you get this rapid extension and then a rapid flexion. So you initially are going to strain anteriorly, and then if it's bad enough, you get it posteriorly as well. I've had some horrible looking cases with that. Now, here's the other thing to think about. Tell me all the structures that could be injured when someone suffers an MVA that comes from behind it, God knows how fast. You certainly could have some back issues, but I'm talking in the cervical spine, what structures could be damaged? Can these muscles get
Yeah, the
strained?
muscles, the vertebrae.
Absolutely, muscles can get strained.
Cause disc injuries.
You can have a disc injury because you've got this rapid force impacting that. Could you snap off a dens? Absolutely. Happens, I don't want to say a lot, but it does happen. That's when you take that open mouth x-ray and you see if the dens is leaning to one side or another. Anybody heard of that one before?
I think you mentioned it.
They will take an x-ray with an open mouth to see if your C2, if that dens, if it's shifted to one side or another, that means there's a fracture. And that's very serious, because if it fractures and pushes anteriorly, you are then paralyzed from C2 down. Okay? A lot of times they have to go in and fixate that. What else could get injured here? Do we not have ligaments surrounding all these things? We just talked about all these anterior, posterior, ligamentum nuchae, all these things that are connective tissue obviously can get sprained, right? So there's lots of things to consider here when we have a high impact injury like that. We talked about the scalenes, lateral and deep. What is the other purpose of the scalenes? How did we find them?
Breathing.
Elevation of the rib cage, okay? With inhalation, they will help to elevate the rib cage, okay? Has anybody seen somebody with COPD or emphysema that struggles to breathe, basically?
Yeah.
Yeah. Have you seen how big their neck muscles are? And their chest is just kind of up like this all the time because they're having to constantly use those accessory muscles to lift up their rib cage, okay? So those muscles get really big and really tight, all right? Mouth breathers, a lot of them. Tough, really tough. Levator, C1 to C4 transverse processes to the scapula, obviously can side bend, elevate the scapula, and downwardly rotate because it comes here to here. So if you pull here, it's going to tip it downward. I think we talked enough about that when we talked about shoulder. Splenius capitis, posterior cranium C7 to T4. Obviously an extender, one side bend and rotator. But I think you think about this majority as an extender, and they work in pair when someone backward bends. Trapezius we've talked a lot about. The posterior cranium and superior nuchal line. To the scapula, to the clavicle, and to the spinous processes, we've got upper, middle, and lower. If we put our arm up in a scapular plane, what part of the trapezius is contracting? Someone remembered from last week? 2 weeks ago, rather. Lower trap. How would you contract the middle trap? That's right, your arm out to the side, the horizontal abduction. How would you contract the upper trap? I don't know. No, I'm just saying. Shoulder shrug. Vertebral spinous processes. You can start at C3, and C7 is the largest, so you'll be able to count that down. What are these called? Suboccipitals. That's all we need to know. Thank goodness. You will hear about the suboccipital triangle, but not from me. You read it in a book somewhere. Suboccipital nerve, dorsal rami C1. Maybe. You never hear from me. All right, so you haven't had this either, but I'm gonna ask you anyway. If you see somebody with this posture, what is that called? Happens frequently in infants and small children. Have I heard the term torticollis before? That is a neck that's presented like that. And usually these are soft tissue problems. A child that lays on one side all the time in their crib, breastfeeds off one side all the time, something that makes contracture occur. You can have problems coming out of birth canal, you can get a strain, sprain. Again, if they come out a different way, you will see babies with this. Treated several of those. Treated any torticollis?
No, but I know people who have.
Yeah, I won't say it's very frequent, but it's relatively frequent. You'll see a little bit of, so what would be tight here, if you're looking at them?
SCM,
SCM, which side?
the opposite side of their limb. Yeah, the same side.
So you can see
That'd be
this one,
stretched.
and this one's stretched out.
Yeah, this was right.
So this side, this left side would be tight, right? Upper trap, maybe scalenes. All those structures would probably be tight here and warrant some work. It'll be so much fun when we get to talk about treatment, trust me. You'll enjoy that. All right, range of motion. Really pretty easy here, okay? Now, we talked about how these are segmental motions. What we're trying to do here is just make this easy. This is accepted, this is the norm, but I want you to understand that all the motion does not come from that axis, okay? Just understand that. But for purpose of goniometric measurement, our axis will be the external auditory hiatus, your ear hole, okay? Stationary arm, perpendicular to the ground. And honestly, you can have it this way, or you can have it this way. Both of those are perpendicular to the ground. Whichever you want to do is fine with me, all right? If you're measuring flexion. So again, think about that though. That's gonna read 90 degrees. Let's say they move down 20 degrees and you read that and it says 110. Are you gonna tell me 110? You're gonna tell me 110 minus what? Minus 90, minus our starting position. So it would be 20 degrees of flexion, if that's the case. Movable arm, base of the nares, just line it up with the nose, people. Really, really easy. Makes it very easy. Extension's the same way. Again, your 0 point, then you would subtract. Lateral flexion is not that much harder, but our axis moves greatly inferiorly to C7. Dorsal midline, movable arm, along the spinous processes of the T-spine. Just line it right on up. Rotation. This one's a little tougher. Again, you've got to be over the top of the patient. So they've either got to sit low or you've got to get high over top of them. Movable arm, tip of the nose. What if you've got somebody with a really short nose? You can't see it. That's when you have them hold something in between their teeth. Tongue depressor or something along those lines. But more times than not, if you get directly over them, you'll be able to see their nose. Okay, so you're gonna line up there. Stationary arm parallel to the acromion. Do not let, that's why you're gonna call it stationary arm. It doesn't move, okay? Get it right in the center of the head. Positioning is important. Here are your norms for goniometry. All right, let's get some practice in. Let's start with flexion.
I can't either. I had to really count my fingers and sit there for a minute.
I'll be sitting in the chair when you do all of it.
Yeah, I think that's probably. I think that's mine.
Okay, and then, $18. I might have slightly been off there because I wasn't super well lined up. She's gonna try mine. Or do you want me to do extension and everything?
Everything and then swap.
I'm trying to be normal, but then I was thinking about it. Very fun.
I need to study Maggie because I need to.
Okay. 42.
Are you reading the red ones?
Yes. Or I can do rotations if you're sitting.
Does posture play a role in this? Yep, you gotta sit up really straight. Common sense people on the starting point and all that good stuff.
Okay, rotate to your right.
I'm sorry.
So what?
No, that's a great question. Do you do passive first? No. I try not to do much passive range of the cervical spine. I'm certainly not going to measure it. I may do it just to see what kind of infill I get. But no, you can start with active on this.
Okay, and then, oh, sorry.
Yes, one side for flexion extension. It'll be the same.
Getting around that same number again, which seems like a lot, but am I supposed to get you?
Yep, you've been on the ball. So.
Okay, let's do flexions first and chin to your chest.
What I have?
7. Maybe?
We'll do the other side.
Yeah.
Switch it up.
Do you think I'm supposed to get you to rotate to the same side? Do you want to, or is it the other way? I would think this is
I'm normal.
okay, so we'll do
First for everyone.
and to the left.
Gosh. Do we have enough pins?
I know, Ariana.
Wow.
She likes to color code.
That was 61. Maybe that's one more. I'll just go with that for now. And then,
Yeah, just like first. Yeah. Alright, go ahead
okay, and then as far as you can to the right. Never mind, I was thinking spine. I almost told you to bring your hand down. Okay. 23.
You start at 90, right? Yep.
Yeah. Okay. But I'm good on the other side of things. That one was very similar to the other. And it starts with 0 right here too. Oh, okay. Red numbers. Red. Yeah. It starts at 0. How do you, oh, you're right.
Which way you want
And then I get on. You can hang out that side. It might be easier. Hang out that side. Yeah.
So what's the next one was side bend, right? It is. Yeah, let me do a rotation real quick.
Are we supposed to do flexion and extension on either side or just the one? It should be right.
Yeah.
Let me flip my PowerPoint so I have the difference. See, let's see. Okay.
Are we lining this line up or the bottom?
I was lining this line.
Crazy.
Starting in here. But I'm looking at the red numbers. Yeah.
Start at 90 on this one too. Think about it, because you're starting at the nose, you're going to the nose, and the extension area is at the acromion. Starting at 90. You got. Yep. You got 59. What's the number?
80.
You can do it. I mean, go ahead.
Do a little rotation. Okay.
I'll stand in that chair. Just get behind you in that chair.
You want me to sit this way or to the side?
Such bad body mechanics on my part. Like, very bad.
It's a lot. But I mean, it's,
I would never really do this. Okay, go to your right.
Oh wait, I forgot. I'm doing my head. Sorry.
Find the middle of your head.
Yeah, these are.
And then
yep.
to your left.
Wait, I'm sorry. I keep wanting to move my whole back.
That one is 54.
Yeah.
No, that was 34.
I got 49.
Okay. Yeah, that one's not
This one is like super loose.
Everybody's math skills appropriate to subtract 150 from 90 and all that good stuff? No?
Okay.
Good subtraction.
And then tilt to your right. Sorry, did you say something? I was listening. No, yeah, tilt to your right.
You can't use outside. Hey, outside red numbers. I love outside red numbers. Not all of them have outside red numbers.
Yeah, I'm telling you, I got 39.
Yeah. I feel like that's the first one. Nobody uses that.
Yeah, can you start with that 0 and black? Yeah. I'll sit that way.
We can do the red numbers?
And then to the left. That was 30.
Good on you.
So if I'm like 40, then I take 40.
Maybe
Doesn't
the picture that I had taken is okay, but I thought it said something which one it is.
Yeah. I don't know. I can feel it when you were doing
Yeah.
when I was doing that.
I've noticed numbers in there
Yeah.
are
This
different.
one's not even close. This is like this is 25, so this is 45. I know this is probably right.
Yeah, I don't see anybody doing this.
My wife
What
hates
about?
change.
I think you had somewhere around there. Yeah, one of the times was 26. Oh, yeah.
There you go. There's your horrible posture. Now, where's your zero at that point?
Do you need me to scoot up?
Sure, that is this. Neck and trunk, but this part is neck and trunk. Yeah.
What y'all get? That's what we got. So she got 39. Okay.
Bring your right ear to your left side.
That one doesn't. No, that one doesn't. That one doesn't stick. Like or whatever.
Oh, never mind. We're good. I was thinking I was
29.
That's why you have, that's the answer to that. Someone with perfect posture, that says they're 90
Look at this hoodie.
I agree with you.
And this one, they, I wonder if people like.
Thanks, sir, 180.
Yeah,
Yeah, but like, it's still zero, it's like 180 zero.
He was straight over there.
Cause I know she said like for the hips.
What'd you need?
Like,
Oh, I
he was
just-
saying,
So
I just didn't know how to do it right.
tell me you have to do that, and then you can't rotate.
Yeah, 30.
And so with this, I wonder if they start to, if they start to do that, so if you train it, if you're heavy to that,
And the normal for side bending is like 45, but in here it's 25.
Yeah, so what's,
Okay.
trying to.
45 seems a lot.
and we got around 20 to 25.
Yeah, I don't think 45 would be correct.
Okay.
I think it's just a typo. That was in the checkoff book? Yes. I'll double check it. You may see
Yeah, probably.
5 to 10 degrees difference in another resource or something like that, but it's not 45. 45 is 45.
Okay, so yeah, you know.
lateral side,
The normal for
45 is too much.
side bend, it said in the.
Well, Norm, she's got a long,
When she was doing rotation, I was getting like 70. She asked a good question, though. She said,
We got 25.
somebody substituted.
Somebody else asked that
So
question.
should we stay?
Absolutely.
And then next time do it again?
Absolutely. You gotta get
Are you
that
reading
out.
the right number?
Where's that motion coming from?
Right.
Probably lumbar spine, even hips.
Great question brought up by a couple folks. You know, what are you gonna see for substitution patterns on this? With side bend, you're gonna see people that wanna do this. Alright, so that motion's coming from down here. Or with rotation, you'll see them do this number to try to achieve more. So you've gotta stabilize them. You can't let them move. Now, it's tough because you've got both hands on this goniometer. You're gonna have to maybe do it with one hand and put another hand on them to say, do not rotate, do not side bend, okay? I always say, when I'm measuring this, which is very infrequent, I will say to them, this is the motion I want you to do. Can you put your chin to your chest? Can you look up at the ceiling and not move? And I always put them in sitting, because that takes out some of the ability to substitute. Put them in sitting. And if I see them start leaning back and all this stuff, I say, no, no, no. Sit there straight. I'll put my hand kind of on their trunk here and just say, okay, now just move your neck. Whatever motion I'm having them do.
Yeah.
You will also see, I think in your textbook shows a chin to chest, this kind of thing, and you measure with a tape measure. That makes sense, right? It's kind of like what we did when we did lumbar flexion and extension. You can certainly do that. There's nothing wrong with it. It's very replicable. It makes sense. But because goniometry is so much easier with the cervical spine than it is with the lumbar spine, this is the accepted means that you'll see. The other thing you might see is that inclinometer, or that little level thing. You'll see that from time to time as well.
And in our checkoff book, it's that cervical section that we didn't do before?
Correct.
Okay.
Correct. But I've seen people measure ear to shoulder for side bend. There's nothing wrong with that. Makes sense. If you keep them in that, what plane?
Side. On the front.
The other side, frontal.
Front.
Right there. The 4, and then we have 3 special type, or 3 special special.
Whose neck does that?
That's not wrong.
Whose neck does that?
We do right now.
This picture is terrifying. If you can get your head like that, I'll pay you money.
That is the dumbest thing I've ever seen. No one would ever do that.
You can't get your head.
Ever.
There's no way.
Absolutely
Very funny.
ludicrous.
Did we do this? Oh, I'm in the wrong thing.
No, just never do that. Never.
It's like, you ever see the Fifth Element? It's like that statue. No way. a cervical issue.
Yeah, if you're here.
Yeah. Yeah, and then let's pick it up and jiggle it around and, it's a great idea. If it wasn't broke before, it okay.
You do that already.
Flexion, extension.
That's what I'm saying. I don't see.
Anybody with any really wild looking numbers?
I'm actually in the normal range.
You're in a normal.
I'm in the normal range.
You probably practiced yesterday for stretching and stuff.
It's a miracle.
I was trying to make it.
The second we do the hip, bro, oh, God.
It's hard to do it like that.
No, this one does alright, cause I can.
So the National Institute of Health, look at this. Cervical spine's range of motion is approximately 80 to 90 degrees of flexion. I'll buy that. 70 degrees of extension, maybe. 20 to 45 of lateral flexion and up to 90 rotation to both sides. The most flexible person we had, you had 70 degrees of rotation? Okay. So nobody's rotating to 90 degrees, I don't think. Seems a bit much. But my purpose of showing you this is that you're going to see different norms with different sources. So don't flip out. Here's normal values from a textbook, another textbook. Oh, they're not going to tell us we got to buy it. Thank you. We're not looking under Cairo or. Let's see what YouTube's got to say.
A diaper this week free, that's week free. Only Pampers Cruisers 3.
Hey everybody, welcome back to Clinical Physiology. In today's video, we'll be taking you through active range of movement testing of the cervical spine. We're going to show you how to perform the test and the key muscles influencing it. If you'd like more information about active range of movement testing, check out our other video titled Why Test Active Range of Movement, as this gives you all the clinical reason you need behind these tests. Now, whenever we're looking at active range of movement testing, we need to think about three key things. P, Q, and R. Pain, quality, and range. If you're not familiar with P, Q, and R, here's a quick recap. If you do know what we mean, go on through to our main video. So as we have said, when testing active range of movement in any joint, we need to consider P, Q, and R. P for pain, Q for quality of movement, and R for range of movement. In terms of pain, if pain is present, we know that there is a dysfunction within this movement, which may be causing our patient's problem, and will likely direct further testing to this area to try and isolate the source of the pain. If pain is not listed as part of the examination, the therapist can move on to the next stage. For example, if there is no pain on active lumbar spine movements during a hip examination, the lumbar spine can be ruled out of the initial investigation. In terms of quality, good quality indicates that the brain and local tissue are both happy and able to perform the movement. So what does that look like? It means that the patient will look very willing to move and have sufficient power in movement with good control and coordination. If these are lacking during the movement, quality can be questioned, and thus likely direct further testing to establish why the movement is of poor quality. For example, weakness, which could be due to a myotomal weakness from a spinal pathology or a deconditioned muscle from the local area. In terms of range of movement, too much or too little range can indicate a dysfunction within the movement and could also help us identify the patient's condition. As a therapist, it is always important to use the range values within your movement test as objective markers and for you to compare the specific range values in each treatment session. It is important to know the range at which your patient's pain starts and the range at which the movement ends, as often these two values will be very different. For example, if we only measure the movement at which pain starts, we do not actually know how much range the patient can achieve. Essentially, a lack of range indicates that there is a stiffness or a weakness which is preventing full movement. So classically, we test active range of movement of the cervical spine with the patient in a sitting position. And whatever posture your patient adopts when they sit on your limb is the posture in which you should complete your tests. So for example, if the patient sits like so on the limb, then make sure you test it in this position, because this is the posture that they use whenever they move their neck during their general day. Do not correct it, because then you're getting an abnormal sign of what your patient normally does. So now that we've done that, we're going to look at the shoulder. And we clear the shoulder by asking our patient to actively flex their right shoulder and then to actively flex the left shoulder, like so. And when we do this, we need to see if this reproduces the patient's pain around the neck area. If it does, or if there's a clear mechanism of injury that links the neck and the shoulder, for example, if your patient generated their neck pain whilst throwing a ball, then you should complete the rest of your shoulder assessment. However, if this test is clear and doesn't reduce the patient's pain, you can move on. And we're going to move on by starting our cervical spine range of movement testing with flexion. In normal practice, the therapist should stand lateral to the patient so you can clearly see the movement of the cervical spine. I'm going to stand behind the patient just so you can see more clearly. We're going to ask our patient to bring their chin down towards their chest like so. And then, if this movement is not painful, we can apply some overpressure by pushing forward on the head like so, to further stress the joint structures. In general, it's important to use the words chin to chest rather than simply look at the floor, as this doesn't reproduce classic cervical flexion. The muscles involved in this particular movement are now shown on the screen for you to look at. Consider P, Q and R. P for pain, Q for quality of movement, and R for range of movement. So in terms of P, classically it is the discogenic structures around the neck that are most irritated with cervical flexion. However, we know from physical examination alone that you can't rule out other structures in the movement. However, whether the patient gets their pain around the local area in terms of the neck or in peripheral regions, you know that cervical flexion has aggravated structures which are causing the patient's pain. So it might well be that changing cervical flexion is going to be a part of your treatment. Next, we need to consider the quality of movement. And to start with, when the patient flexes, you should see whether the flexion is coming from the upper cervical spine or the lower cervical spine. So, for example, in terms of the upper cervical spine flexion, the patient may notice where the lower half of the cervical spine is very stiff. It may also be the case that, in fact, they're achieving too much lower cervical flexion, like so, where you can see that there's a lot more flexion in this region. Either way, consider if that kind of position aggravates the patient's symptoms, because if it does, it might be the lack of lower cervical spine flexion or the excess of lower cervical spine flexion, for example, that might be triggering their symptoms and might be something you need to test further. Next, we're going to see if there's any particular side flexion whilst the patient flexes their neck. So, it might be that when the patient flexes, they bring their head down to the right as well as flexed, or down to the left as well as flexed. This might be for a couple of reasons. It might be that they've done this intentionally as this relieves their pain rather than if they flexed with their head going down the middle. It might also be that there is a weakness or a stiffness somewhere around the cervical spine that is forcing it to produce this movement. So again, this is something you might want to look at as well. So that's in terms of Q for quality. And finally, R is for range. The normal expected range in movement cervical flexion is 50 degrees. So if the patient is not achieving this, that shows that there is either a stiffness or a weakness that is preventing movement. In general, within the cervical spine, flexion is an open packed movement. So that means that there is not so much stress on joint structures during the movement. However, it may be that soft tissue is being irritated whilst this movement is occurring, and so this is something you consider as part of your assessment.
Starting tomorrow, this simple bedtime ice hack can change your life. You may not know this, but the biological difference...
Anyway, that was more of a
So next we're going to test cervical extension.
PT-based evaluation technique, but makes good sense. Think about pain, think about quality, think about the range. Pain can influence the quality, which then influences the range. So just things to think about there. We'll try to all say cervical so we sound smarter. Yeah, I did a good job with that.
Why does it always just say very small when you
All right, now for the dumb part of the lecture, the manual muscle test. So silly. Here's where it breaks down capital flexion and extension into combined. These are the muscles for capital extension versus all of cervical extension. Have you ever done this?
No, I've done rotation now.
Why would you do rotation?
Because the PT did it. That's the only reason why I did it.
Why they did it? Were they an athlete? I mean, like a wrestler? The only time I've ever done it on wrestlers or football players.
No. I guess maybe not MMT. It was more just like resisted.
So like a Syriax,
For strengthening
selective
purposes.
tissue tension testing type of thing?
Isometric,
Yep.
yeah.
Yep.
Not necessarily MMT.
Okay. Yeah, I don't think I've ever seen this done.
I've seen a guy, never mind. Using the leg extension, doing that with his neck, in Houston Health, yeah.
Wow.
I didn't stop it. It's not, I didn't see it, it's not my problem. He was taking the part that you extend up and using that with his neck.
Wow.
Yeah.
So there's no way, shape, or form. I can see this one to an extent because it's active. But there's no way that I'm going to push on anyone's head and neck with downward motion in this position. That makes zero sense. But I guess that's what it says. Flexion. Again, you've got capital flexion, cervical flexion, combined. And again, there's no way that I'm pushing on them right here. But I can see this. And again, the only time I've ever tested, and it really wasn't a manual muscle test, was testing the strength of someone's neck was with a high school wrestler or a football player that's gonna be in the trenches working, you know. I wanna both of them had neck injuries, and I'm just trying to make sure that they're strong enough to go back to their sport. It's more sport specific than it was manual muscle testing. Rotation side bend, again, not gonna happen. But let's set some groundwork here. What do you expect from them on this?
For cervical?
For checkoffs.
Oh. Just know the positions.
Certainly no hands-on.
Mm-hmm.
If you know up to grade 3, I'm gonna be thrilled with that for extension and flexion. These are certainly open game here to ask you muscles that are prime movers and synergists and so forth. Flexion, rotation, and lateral flexion. Again, I'm not putting my hands on someone's head and asking them to resist my movement there. That doesn't make any sense to me. So grade up to grade 3 and muscles that are responsible, that's what you're responsible for.
Correct positioning of the
Yep.
patient, essentially.
Yep. Vertebral artery test, right? Did you guys do vertebral artery test in school and all that? Okay. So this was big when I was coming out. As PTs, we had to do vertebral artery tests every time. We talked earlier that vertebral artery supplies blood to the brain and spinal cord. Kind of important, okay? What's the population that would have compromise in the vertebral artery?
Neck injury.
I'm thinking more general.
Oh.
Geriatrics. Geriatrics, okay? They've got more problems with arteriolosclerosis, fatty buildup, even hardening of the arteries, which is arteriosclerosis, correct? Did I get those right? Athero and arterial, okay? So that's the population that if you're gonna do this test, you would do it on. So when I was in school, we were taught you have to do a vertebral artery test on every patient that you do any kind of cervical exam on. And then we had a guest speaker come in who was a renowned neurologist. And he says, we asked him, you know, he's going through his exam and someone raised their hand and said, you didn't do the vertebral artery test. Well, and the vertebral artery test, as you can see here, is what they call a quadrant position. You put them in extension, side bend, and rotation to one side to stress it on the opposite side. And what you're trying to do is apply tension to that artery, okay? And he's like, why would I want to do that? If I've got somebody with a compromised artery and I'm trying to stretch it, and they have a stroke in my hands, is that a good thing? That really kind of made sense. He says, so many of you guys are going to be practicing on your own. You'll be the only PT there, and you've got somebody in this quadrant position, and you see their eyes roll back in their head. What are you going to do? Are you going to sit them up and say, sorry, you're having a vertebral artery stroke, let me go call 911? No, he goes, you've set yourself up for mounds of lawsuits, okay? Because you're never going to practice again if that happens on your watch. He says, so there's no way I would do this test. He goes, this is beyond your scope, in my opinion. And I think he's probably right. I've quit doing it since I heard that. But yeah, our professors everyone's got to do this test. So we're not going to do this test, but you do need to know what it is, okay? And again, it's this quadrant position, head off the table into extension, side bend, and rotation. You're stressing the opposite side. What would be a positive test?
I have a stroke.
It would be a positive.
I knew it.
Lesser symptoms than that would be nystagmus. Anybody know what nystagmus is? It's when your eyes twitch really quickly. Okay? I don't want them doing that either.
That doesn't sound good.
Yeah, close to having a stroke but not having a stroke. So if you see a therapist do this and you see nystagmus, then that is a positive vertebral artery test, and this person really should go for further diagnostics at that point. And you're not to do any kind of treatment on them with that. So that's a vertebral artery test. Yeah. This one you are going to see, and this is one we will do. Everybody get in position here for the foraminal compression test or Sperling test.
You ready?
Before we even start, does anybody have any cervical spine issues, any problems with shooting pain, numbness, tingling in the hand as a result of the neck, anything? Okay. All right, you're going to get your patient in seated position here. You're going to have them in a good posture because you're going to apply an axial load straight down. Okay? I always do it straight up and down first, and then I tip them to one side and apply that load, and tip them to the other side and apply the load. Symptoms. Usually pain.
Hey, relax. Everything's gonna be okay.
Is that mine?
No.
No.
I feel like going
No, just more, it's more of a side note.
I guess that's what. Maybe it's
I would describe
Hey, you want to switch in?
I'm not pushing hard because it's scary. It says it's supposed to test the nerves, but I'm
It's like spring.
okay. I won't change it because this says
You don't even do this.
I don't know if I will. Did you feel anything?
Positive finding. Pain and tingling in the upper extremity is positive.
Wait, was it
Pressure on the nerve root. But look, if you hit on somebody, you got an
YouTube it
anomaly.
in there.
Just on somebody, and they just had localized pain. We just did that on,
That's what they're looking for when
Rebecca.
they do it.
I would say positive pain reproduction, localized pain.
They've tested me already. I have a friend
But
that's
tingling pain is what
state
you're looking
control.
for.
Maybe I should have started that. But that's what they look for when you try, and then their eyeballs will literally look like the ground. So it's gonna be very different. I should have.
So you gotta do right.
No. I will not be practicing.
Oh.
Oh, no, you don't. She asked a question. You asked.
Even if you have stuff.
Sir, how does that feel?
There's a lot of class.
Any pain?
Take a lot of like
Very good.
letters.
No, very good. Not my favorite.
It's mixed in with the other. It's mixed in.
How it felt.
It wasn't a lot.
It's more read over there.
Yeah, you're not like he's not dropping it down.
But you're not putting it
firm.
You're putting them in that.
Firm pressure.
Like putting them
Not just with your body weight.
I would mind.
Like he wasn't doing one motion.
I think it just depends because I have to do some upper body.
Yeah, because we were doing it as one motion. So it's not one.
But I'm
Yeah.
Okay, that makes more sense. I'm not sure.
So what?
So, when Allison did this on Rebecca, she got pain on the right side, but it was very localized. Is that a positive finding?
No.
According to this test, it is not. However, it's just like a straight leg raise to me. I want to know that. That helps me determine something else. So I would put in that chart, I would write right Sperling's positive localized pain, right upper trap or wherever you felt that. Not shooting down the arm. Because if you just put positive, you really don't know what it is. So describe what you get, all right? Pretty easy test. This is one you will see all the time. Here's the great part about this test. Promise I'll be nice. So it was right side, correct? Okay, so I get her over here, I apply pressure, she says it hurts. Well, instantaneously thereafter, what I'm gonna do is just the opposite. I'm gonna lift her up. And that feels good, most times, okay? If you can distract somebody's spine when they have pain with compression, you're gonna make a friend, I promise you, okay? We'll talk a lot about traction here in a few weeks in modalities. But that is a really, really simple way. It gains, the patient's gonna gain confidence in you as well because you've created pain and you took it away. All right? So you're building that bond with them as well. So that felt better? Okay, so then I would lay you down and we would do lots of traction, and you probably would feel great with that, okay? So if there's some pain-provoking test that we do, I'm trying to follow up afterward with some kind of treatment that's gonna address that. Make sense? Okay.
What's the correlation with this test with vestibular treatment?
Oh, good question, I do not know the answer.
I was watching a vestibular and they did this test, but I'm not pushing pressure, you're not doing anything.
They're more about positioning.
Positioning.
Yeah. Be a great question for Tina.
Okay.
We have a vestibular expert that will come in the fall. Mark that down, we'll talk to her about it.
Okay.
I do Epley's maneuver on my wife, done it a lot lately, because when allergy season comes, she gets a lot of vertigo. So we've been doing, you guys know Epley's maneuver? You ever heard that? Hang on. There's all kinds of videos on that.
Y'all will learn how to do it.
Yeah, you'll learn how to do it. Why's our volume so low?
Is it up on the computer?
I think so.
I was down to talk to my doctor about Rybelsus.
Ask your healthcare provider about Rybelsus today.
Normally, only with head movement does fluid within the inner ear also move, informing the brain that a head turn occurred. However, should a crystal called an otolith gets displaced into the posterior canal of the inner ear, BPPV dizziness occurs. Fluid movement occurs due to the crystal rather than head turns, causing the brain to think movement has occurred even though none has happened. The Epley maneuver is performed to treat this posterior canal BPPV by trying to get the loose crystal out of the canal. This maneuver is started by turning the head 45 degrees and the body laid back such that the head is extended about 20 to 30 degrees. If BPPV is present, eye twitching called nystagmus will occur. After 30 to 60 seconds, the head is turned at 90 degrees to the opposite side and held for another 30 to 60 seconds. The head is then further rotated another 90 degrees, accomplished by having the patient turn onto their side, which is then held for another 30 to 60 seconds. At this point, the head should be turned 45 degrees from the horizontal. When performing this maneuver, another individual can help with these position changes. The maneuver is then completed by having the patient sit up. So what's going on with these position changes? Essentially, the head is moved in such a way to manipulate the crystal to fall towards the canal opening. With each position change, it takes about 30 to 60 seconds for the crystal to settle into the most dependent position in the canal. If turns are made before the crystal has a chance to settle, the crystal may fall back the wrong way and the maneuver will fail. It's also important that the head positions are angled correctly, or else the crystal will not settle to the correct position in the canal and the maneuver will fail. Also, if the position changes are done too slowly, the crystal may not settle quickly enough from lack of momentum and the maneuver will also fail. Once the crystal falls out of the canal, the dizziness should resolve if due to posterior canal BPPV.
BPPV is benign positional something vertigo.
That's a good guess. No.
I think that's close. Anyway, we'll talk more about this in the fall. And that's really the only special test we have in the cervical spine, which is nice. TMJ, we talked a little bit about it. Why don't y'all go back and take some notes on this stuff, or at least get it on your computer.
Benign paroxysmal positional vertigo.
I got 3 or 4, that's pretty good. Proximal. P-A-R-O-X-Y-M-A-L. TMJ. Mandible, disc, and temporal bone. So this upper joint, this convex articular eminence, concave mandibular fossa, and superior aspect of the disc. I'm not worried too much about this whole anatomy thing. Just know you've got a very convex condyle. It's going to fit in a very concave mandibular fossa with a disc in between. Okay. Remember they said in the previous lecture this morning, the disc is kind of like a lifesaver. It's designed for pressure relief. Okay. If you open up and then you laterally deviate, you will feel probably a lot of clicking too. There's the disc. And here's our anatomy. This is what I was talking about with the nerves. Trigeminal nerve, cranial nerve number 5, 3 divisions. You've got an ophthalmic that innervates the eyes, maxillary that's going to innervate the top part of the jaw, the maxillary region, and the mandibular, which is going to come all the way down here to the mandible. 3 sections. Facial nerve, 5 branches. Cranial nerve 7. Temporal, obviously. Zygomatic to the cheekbone. Buccal branch to the cheek. Mandibular, lower jaw, and then it's got a cervical branch. Provides motor for the muscles of facial expression, all those ones we talked about this morning, and sensation for 2/3 of the tongue. Which part of the tongue? The back 2/3 or the front 2/3? 50%. The back 2/3. What innervates the first third of the tongue? Trigeminal. Okay. There was a board question. Did you look at 360 the other day?
Yeah.
I had a question on this. So again, I don't get too caught up into this, but it will say the upper joint, lower joint, all this type of thing. But again, 3 planes and 3 axes. Depression, elevation, protrusion, well there is the word retrusion, protraction, retraction, and then right and left lateral excursion or deviation. 3 planes, 3 axes. If you're palpating, start up high. Orbital fossa, I don't think you're going to see anything out of the ordinary there with TMJ. Cartilaginous septum, you can feel, if you feel your nose, the top of the, not all the way up at your nasal bone, but here, how pliable that cartilage is, okay? Zygomatic arch, the zygoma, the cheekbone, obviously slightly convex. Masseter muscle we got earlier, below the arch, clench the teeth. Rectangular to square shaped muscle. Temporalis, above the mandible. Clench the teeth, you'll feel the contraction. Mandible, all the way to the angle, to the external cartilage of the ear. Again, you can palpate TMJ 3 different ways. We'll talk about it in just a second. External acoustic meatus, feel TMJ just anterior, or you can palpate, you can actually put your finger in someone's ear. I can help you palpate it. You can also obviously go internal to try to palpate that. Okay, if we've got more muscular tightness in the buccinator and all the muscles through here, that is how you're going to do that. So you can choose that to do that or not to do that. So dysfunctional movement. If you have somebody open their mouth and it just automatically goes to one side, that's a dysfunctional movement. That would be a C-shaped curve, a lateral excursion to one side. A lot of times what people will have is an S-shaped curve. It's a compensatory. They will open and they will laterally deviate and then it will come back, okay? That's got to do with some kind of structural deformity there at TMJ most likely. She's probably just got this C-shaped curve with this lateral excursion. And again, the way you measure this is between two teeth here and two teeth here. See, this would be how far this is here. From here to here, probably, I don't know, at least, guessing a centimeter at least. Measuring depression, you measure between the upper and lower incisors in full depression. Normal is 35 to 50 milliliters or 3 fingers widths. How many fingers could you stick in their mouth? Okay. You like the ruler better? In full mandibular protrusion or protraction, that usually measures about 7 to 8 millimeters. I don't know many people are going to let you put their goniometer in their mouth, but you might have a few. Lateral excursion, 9 to 11, that's what I was thinking it was, something around 10. Should be normal. Center upper incisors and center lower incisors, you're going to measure this to here. And that should be around 9 to 11. I had a patient one time, didn't have any upper teeth, so it was guesswork. I went by the split in her lip, and I didn't know. Luckily, I didn't get a lot of that. Muscles of mastication. Actually, let's go ahead and practice these TMJ motions and measurements. Start with TMJ depression. Go. You take a break, you need to.
You going rusty? I'm like, I think everybody's like, I'm fully touching my feet.
Still, I don't like anybody getting anywhere. So like, here, over there. You gotta face me. Dude, my fingers are clean. No, I'm not saying in your mouth, but I can see right here. It's like a snake. I'm not trying to insinuate anything. I'm being serious. Like,
My son is trying to get me to take him to see Bear on cocaine.
Yeah. Apparently it swept the Oscars. I saw some news story about it.
Like, are you serious? Who went to see it?
What?
Have you seen it? Bear on cocaine?
Yeah.
Or cocaine bear?
No, but I wanted to go.
Because nobody wants to spend $25 on a ticket.
See, he's intelligent this fall. They've already planned it because they've made so much money. Yeah, they've made so much money.
They have, there's a movie on Amazon called Meth Alligator.
I don't have to do it.
That's what I'm
I
trying
don't want to
to
do
do.
it though. I don't think anybody's doing it. I think everyone's kind of just sitting around.
This is what I want. Will Smith can slap people with cocaine bear drink winning Oscar. Alright, Brendan, open up.
That's your face. Okay.
We got any watch yet?
What's normal? Okay, so yeah.
I'll
And
go
you were right last time.
they're up in the back.
150 today. I mean, that's it.
I don't mind putting it.
Yeah.
I'm sure it's.
Oh, no, wait.
There's only like 3 Here, let's ask Google. Centimeters, which is. One centimeter is equal to 10 millimeters. 1 centimeter is equal to 10 millimeters. Okay. I don't even know the number right now. That's a lot of deviation. That's a good bottle. Oh, yeah.
Because I was looking at it and said that she said
I'm not putting that in my mouth.
you just said that I had to.
Unless they want us to start there, which is the question. 35 or 50. Or 3 fingers to it. I'm not putting my fingers in your mouth. We don't have one that goes up that high. I guess if we had a oh, it goes all the way.
Oh, it's got millimeters on this.
It doesn't make sense.
Because I was like, I was not looking at that, saying that was more. And it gave us that between 12 and 42.
Maybe it's like the difference, so maybe like 20. But still, there's no mouth open in that one either.
And that's definitely not 3 fingers.
No.
Line up this line at the top.
That's a lot. I don't feel like that
That was just in the others, but I'm still thinking. And see right here, it's only going to.
but even then it wouldn't be.
Yeah. Right there is 7. And it's nowhere near the so I'm not here.
Nobody else is doing it. I wouldn't do that one.
It's yeah, it's not, yeah.
As long as we have an idea. Surely they haven't asked that. Check it.
I didn't see it unless they're mad.
So did you have one here? Excuse me. Or this one's not for you either?
I don't like that. It's
We won't have to
What you do, just stick that in there and try to get it closed? Yep.
Just stick it in between there, there's no right to work. Yeah, that's okay. You probably just stick it in between.
Make up use his.
Dude, that's mine. I don't know, man. I was like, don't worry, I'm gonna go to the university. Don't worry. But I can't do that.
So, I feel like it's
You got like.
I know.
That's true, the latest one was, and I feel like for the rest of you guys, it's just like,
I think it would start there, wouldn't it?
that's a lot.
It
is zero.
I'll take 10 off there.
A lot of them, yeah, since you've been in the course with the region of the skull.
I mean, it's kind of weird, I'm not gonna lie.
What was your
Hers? Mine was 50. I actually did that. I actually did 50.
I said hers was 35.
35 to 50. Mine's about.
She got 60.
Yeah, I was I didn't think hers was very good.
Yeah, 5 normal and then.
I was actually kind of surprised.
No one's using this big one right now, they're not.
My inability to
They're all using this one.
more often as social.
I don't want to really try to make it.
Yeah. Sucks for you. Yeah, this is the book they gave us for it. Yeah. This guy just threw it in there.
Because that's obviously interesting. So what's does that look like something else? Then I'm gonna
sweat a lot more than you. Say for me, we can just start that.
10 millimeters in a centimeter, people.
we're converting. I don't.
Which makes sense.
I was like 10 centimeters. Those are centimeters. They look like centimeters.
Everybody measure the protrusion yet?
Just call that one good, Doc.
Get out of the landmarks.
I didn't come to store and put some tracker.
This one is centimeters right here. So millimeters, smaller than that, but they're not on there. Unless we.
Well,
I'm not good at that. We have to do that. Yeah.
it's always a need.
Can't be much.
Yeah. A lot more people have ankle problems.
We got our TMJ
I'm just
subject.
gonna have problems.
She won't be here Monday.
We need a circle anyway.
So 1 centimeter equals 10 millimeters. So that would be 10, 20, 30, 40, 50.
Well, that makes more sense.
Yeah, that makes much more sense.
I'm still not with it.
Yeah, that leaves no end.
We know.
It's terrible. I take turkey sandwiches and mashed potatoes. It's stomach disease that like things like the lining of your stomach or whatever. And essentially you can't eat like anything except for like raw foods for like 2-3 days. You can't drink. You can only have water, no soda, so no like juice or anything. Do you know how many lost?
Why just 2 or 3 weeks?
There's like antibiotics that you're taking it, but what, here's the thing, like, say with you, for life. Cause I got it freshman year, but the thing is like you can like manage it. And usually what you're supposed to do is if you have like a flare, like let's say you go to you go home, really have a flare up. Alright, just don't eat out, don't drink, blah, blah, blah. See what I did is that I went to Mexican and drank then burger.
You know what you could do is you could put a tongue depressor
They
in
made me
there.
drink. It was
In the market.
now I
Don't
do.
make them drink.
Because they said Levi. No, they really did because they're like, you'll be fine. What you drink, you won't be thinking about it. Well, I didn't know it was H. Yeah, because I didn't know
I haven't seen, you have
So
the.
this time, because that's what the thing is, like you can manage it, right?
Like what would be normally.
See if it listen. Twitching.
You can measure flexion, extension, rotation, lateral flexion.
That's what this says.
She was like, oh, she uses pretzels all the time, cause it was like, I'm gonna look it up, I'm just.
Facial muscles will contract and twitch at blood I've heard of stuff like I can't drink red. If I drink red, I'll throw up, but it's not because of my stomach, it's because of external factors.
There's some palpation.
It's like my body sees it and then just pushes back in. Because some of it can be mental. It's not all like chemical.
Yeah, if you get two, that's.
But I've never heard of somebody think go around.
Yeah.
Pretty.
Cause it's.
Yeah, but it's like only brown though. Usually it's only one. So you get two that's green.
Usually it's like artificial.
Exactly.
Yeah, that's what I was
Not for my own chin.
Maybe this girl's just making it work, I don't know.
Makes you
Kind of
drop
springs
shit.
cry for attention.
Yeah. I don't want to do that.
He goes into a lot of details about this location. You know what's gonna be crazy? If I go through this and it's like, oh yeah, no, you have something completely different. Oh, I just so bad. But it's plausible though. I've never seen it.
He did.
We will have a check-off on ultrasound. All the other check-offs.
My mom says, "Steve, you can just."
No, it will be on Thursday.
What did she got?
Thursday, the 23rd.
Just watching channel because that's the only reason why I do that answer that question. That's my mom when we talk about it.
That's a whole lot better than those new stuff they write that
All the
down.
other ones that we're doing.
Pretty good. It is very good.
Yeah, I haven't had a
Ultrasound too.
That's great.
Pretty good.
I'm farming. Go.
Muscles of mastication. Your chewers. Elevation, especially bilateral masseter, temporalis, medial pterygoid, depression, lateral pterygoid, suprahyoid, get down. Lateral excursion, bilateral pterygoids, protrusion, same side lateral pterygoid, opposite side medial pterygoid.
Do you push on people's faces?
I have before. Look at this manual muscle testing. Actually makes more sense. Functional appears to be normal. WF, weak functional. Moderate impairment with effective degree of active range. NF, non-functional, severe impairment. 0 absent. Wouldn't that be nice?
Are they pulling their head down in elevation? Like, what is it, what's going on right there?
This one?
No, they're stabilizing the head and pushing the.
That's
Chopstick sign, I forgot that one. Tap in here. At the parotid gland to see if there is facial nerve irritation. If you see twitching or shooting pain, indicative of facial nerve pathology. Twitching can also be result of low calcium levels in the blood. Pathology? Do you agree with that?
Say that one more time.
If they are twitching, it can also be the result of low calcium levels in the blood.
Yes.
So it's tetany at that point?
Yeah.
Interesting. Again, here's the palpation for TMJ. You can go right over the joint. You can go in the ear, or you can go internal. Palpate all of those. And again, we don't have any TMJ on checkoffs, but you should at least try to practice this, even if it's on yourself, just to get an idea of what to expect there. Do we have anybody that needs TMJ at any point? Not that I know of.
Like, again, it's not we don't have a clinical that specializes.
Oh, certainly not, but I just didn't know if anybody saw a random here and there.
Not that I know of.
Yeah. It's not something you're gonna see a bunch of, and I wouldn't consider it an entry level thing. But they can put this on a board exam. I think that's it. That is it. Anything we need to review? Basic mathematics.
So you just find the zero on the other side. Okay, so I'll do it. I try to do that, and I'm trying to use the calculator and the clinical and all the things. I was so read your book. To this day, I know what to do. Do not
But it depends. They make fun of your math skills, and they make fun of you to do it.
They make fun of me.
Really? What if you don't have red numbers on it? Because a lot of them don't have red numbers.
I just still get a lot of crap for it.
Did we get a team name that?
What do you mean, Justin Canizo?
Yeah, that's like the.
Like I didn't have anything.
Over what, 26?
Isn't that all up in Logan's mouth?
No other,
I don't
no
have
double
any
major.
degrees. I got a diploma.
Yeah, that's what we got.
I gotta get better at that.
26 bucks. That's the kind of stuff they'll give you away at the health fair.
Yeah, you have no idea how to do it every day, but I don't know how to. And I just got over.
So she gives away from the country.
Pencils, pens. Yeah.
Go. You ready to go?
Wednesday, more practice.
Dude, no gallery tomorrow, bro. It's not gonna be fun. I mean, ultrasound will be fun, but dude, we'll see. It's either gonna be
Go out. Well, we did 2 classes in one day. We did 2 classes in one day. Oh, I thought you were talking about this one. You said you had to consider.
Add